Good day, everyone. Welcome to Just Us Coordinating Council Speaker Series. My name is Stephanie Hicks. I am the Business Operations Specialist for Urban Alchemy in Birmingham, Alabama, an Emerging Leaders participant and member of the Just Us Coordinating Council. I am honored to be with you today as moderator for a topic that is close to my heart and critical for the future of our work, caring for those with a conviction history who are aging. The JCC, as many of you know, is the first of its kind national policy table created by and for individuals impacted by the criminal legal system. Over the course of the last 2 years, 2.5 years, we have built a table dedicated to advancing economic justice where everyone is welcome and all who are invited have a seat. This is a table where collectively we can leverage our lived experience and as expertise it is. Today's speaker series features a trio of experts whose cross-cutting work empowers aging justice and helps support access to basic human needs for all they serve. We will hear today from Olivia Umaran, Director of Policy at U.S. Aging, Rachel Gershon, a senior attorney from Justice in Aging, and Dr. Ron Self, former U.S. Marine and founder and executive director of Veterans Serving Veterans. Before we dive into today's session, I wanted to take a moment to orient those of you joining us today to exactly why the JCC is truly a first of its kind approach to policy. The JCC is a national federal policy table led by and created for individuals who are directly impacted. The JCC forms the connective tissue needed to catalyze full participation in policy practices and changes for formerly incarcerated people and directly impacted individuals in their communities. The voices of the most impacted by the criminal legal system have been missing and/or excluded from decision-making tables. Priorities: collateral sanctions, housing, health and well-being, sentencing and reentry, and employment. Elder justice, a multi-priority effort. Collateral sanctions, housing, health and well-being, sentencing and reentry. But the elder justice is a concept essential to economic mobility is often limited for the person returning from incarceration, both by their changing basic needs as they age, as well as diminishing funding and access due to changes in federal programs and policy exclusion. The legacy of mass incarceration has created a reality where the average age in prisons is climbing. Often traditional programs may not be equipped to adequately serve the needs of reentering seniors. The advocacy community's efforts have historically not fully addressed the intersectional issue. Centered back to people. Which brings us here today. According to the National Commission on Correctional Healthcare, by the year 2030, 30% of America's prison population will be over the age of 55. This reality will require policy and programmatic choices at all levels of government, including empowering individuals living with convictions to remain in independent housing and access basic human needs. Policymakers and advocates alike may not know the services that exist that can aid in reentry planning. Central to these services are both federal funding and its service providers where the rubber meets the road. U.S. Aging is an association of the nation's area agencies on aging, or AAAs, from advocating for federal policy change to supporting their members that partner with social service providers. U.S. Aging has served as the national voice for AAAs and those they serve since 1975. Here to share more about key national policies and programs that support impacted seniors is Olivia Umarin, Director of National Policy at U.S. Aging. Olivia, thank you so much for joining us today, and we look forward to learning from you. The floor is yours.
Thank you so much, Stephanie, and thank you to the JCC team for inviting me to speak today. Good morning or good afternoon, depending on where you are. My name is Olivia Umarin Ezuko, and I'm the Director of Public Policy and Advocacy at U.S. Aging. Next slide, please. U.S. Aging, we are the National Association of Area Agencies on Aging, also known as AAAs, and we also advocate for the Title VI Native American aging programs that assist older adults with aging well at home and in their communities. The goal of this aging network is to ensure that older adults can remain where they are most comfortable, and where they can have the most supports as well. Next slide, please. Next slide. So what is a AAA? Formally established in 1973 in the 1973 Older Americans Act as the on-the-ground organizations that are charged with supporting older adults in the community. For 50 years, AAAs, they've served as the local leaders on aging by planning, developing, funding, and implementing local systems of coordinated home and community-based services that enable older adults to age well at home and in the community. And AAAs, they develop area plans on aging and then lead local networks of providers to deliver these person-centered services to older adults and caregivers. They're known for cost-efficient and effective, and for leveraging public and private resources in innovative ways to best meet the needs of older adults in their communities. Next slide, please. So here you see a picture of President Lyndon Johnson signing the Older Americans Act in 1965. And the Older Americans Act is really what represents the national commitment to assisting older adults to age well at home. It's the cornerstone of the nation's non-Medicaid home and community-based services system. And each year through this, nearly 11 million older adults receive critical support from the nationwide aging network, which consists of not just AAAs, but the Title VI Native American aging programs, and then tens of thousands local service providers. Next slide, please. So here you see the core services that AAAs provide, which is nutrition, supportive services. There's services provided for caregivers as well, health and wellness programs such as evidence-based programs, physical activity programs, and as well as elder rights. Next slide, please. So the Older Americans Act is a big act. It does a lot, but sometimes this is often an act that not too many people know about. So there are 7 titles in the act, and these were added over time. And this is an act that has reauthorizations, and there's reauthorizations. Before it was maybe 3 years, now it's closer to every 5 years that the act gets reauthorized. And what that means is when there's a reauthorization, which we're currently in right now, it's an opportunity to update this act to align best with the needs of the older adults of today. So you can imagine maybe the needs of older adults 50 years ago were not going to be the same as the needs of older adults today. So reauthorization helps to make sure that the act is basically keeping up to date with the people and with the times, and making sure that the act is still serving older adults in the best way possible. So Title II, this is really just more of a general background on when it was established. And then Title III, this is the largest section of the Older Americans Act and funds the bulk of services. So this includes Title IIIB, which is those home and community-based services, things like in-home services and supports, in-home modification, assistance with laundry, things like that. Anything that you would need assistance with in your home, This is supported through Title III-B funding. And you have Title III-C as well, which is the most well-known, as this is what covers congregate meals and home-delivered meals. I mentioned evidence-based disease prevention and health promotion programs. So things like Tai Chi, yoga, any other physical activity programs or programs that can assist with disease prevention, chronic disease prevention. This is the title that helps to provide funding for that. And lastly, here we have Title III-E, which is the National Family Caregiver Support Program. And this is something that is a critical program for older adults. We are now seeing that caregiving really is a job in itself. So in addition to providing those wide range of home and community-based services I just mentioned, AAAs, they also provide critical services to family caregivers of older adults, as well as older adults who are caregivers for younger relatives. So there's an estimated 53 million unpaid caregivers in the US, and it's been very clear that family caregivers need a lot more support than they did before. So this is something that helps to provide support for that. Next slide, please. And here is just a list so that you can have some type of understanding of what those services involve in terms of the Title III-B supportive services. So basically, again, everything that you need in order to live at home in the most comfortable way possible. Next slide, please. And another aspect of this is information referral and assistance. So there are local hotlines that will connect callers to home and community-based services. So if you're somebody who is either in need of service, or maybe you have a family member or a friend who is in need of service, you can call your local AAA to figure out the best way to get them what they need and to be connected with the proper resource in order to help you or to help that family member or the friend. Next slide, please. So we have our elder care locator is our national call center, and this sits right across from my office. So I get to hear lots of the calls that are happening throughout the day, and people call about, with questions about Medicare, though that's not for us, but it's a common question that comes up. But really, people do call to figure out how to either help themselves or help a loved one or a friend or anyone else who may be in need of assistance. And what this call center does is it connects the individual who is calling with either the correct AAA or the correct person to provide them with additional assistance. And as you see here, the call center is open from 9 a.m. to 8 p.m. So those are the hours. If you ever need anything, this is the number to call. If you're confused or you don't know where to start, this is the perfect place to start to figure out what kind of resources are out there and what kind of resources you can get connected to. Next slide, please. So again, here, just some more examples of the programs that are included. I want to touch on the evidence-based disease prevention and health promotion services. So this is also including falls prevention programs, chronic disease self-management programs, and other wellness and socialization programming at senior or community centers. And it's important to note that the OAA is for all older adults. It does not exclude individuals with conviction histories from these essential services. So feel free to call. It does not matter what your past has been. It does not matter what you've experienced, but these services are always going to be available. Fingers crossed. We're hoping that they will always be available funding wise, but they are available to all older adults. Next slide, please. So one thing I want to flag here before I go into the two other titles, there's a Title V Senior Community Service Employment Program, which is a low-income community service employment program run by the Department of Labor. The other OAA programs that I mentioned, they're actually under the U.S. Department of Health and Human Services, and Title V is the only one that is not under Health and Human Services for the obvious reason, because this is more in alignment with DOL here. And in addition, we have Title VI, which is the Native American Aging Programs that I mentioned, as well as Title VII Elder Rights. So this provides funding for long-term care ombudsman programs, elder abuse prevention, and some legal services. So we've been hearing a lot about scamming, about financial challenges in terms of certain individuals targeting older adults, whether that's somebody random or a family member. This title provides funding to assist with getting out of situations like that or preventing situations like that from happening. Next slide, please. Next slide. So I mentioned the Title V Senior Community Service Employment Program, and this is really very relevant to the conversation that we're having today because this is the nation's oldest program that provides community service and work-based job training opportunities for older Americans 55 and over. So it matches eligible older adults with training assignments for nonprofit organizations. And for most, the CSEP experience, it's called CSEP for short, it leads to permanent employment. And the enrollment priority, it's given to a lot of folks, including individuals that are reentering from incarceration. So this has been a program that has helped a lot of older adults get the work that they are looking for or get the training that they are looking for. And it has been, at the same time, a bit of a controversial program at the federal level, which I'll talk a little bit more about on the next slide. So why am I saying that this has been controversial? So this spring, the president's budget for the U.S. Department of Health and Human Services, it called for the elimination of this program. I want to note that the president's budget is just a proposal. It's not something that is implemented. It cannot be implemented unless both the House and Senate agree to implement whatever they pick from that budget, or if there's something that mirrors the budget. So this was really just a guiding tool for when Congress started their annual funding process. And the Senate proposed to keep the program, but they cut funding in their proposal over the summer. And as of last week, the House proposed to eliminate the program entirely. So right now we have two options. It's either A, we keep the program and the funding is cut, or B, the program is eliminated entirely. And the future of this program is really not clear, but we are beginning to see some of the domino effect of these elimination conversations in terms of, for example, some AAAs having to lay off staff because another layer to this is the funding for the CSEP program this year has been delayed. So unfortunately, a lot of AAAs and other organizations have had to lay off their staff that support this work. And this is very important to note because there are some implications related to this that are related to the One Big Beautiful Bill Act, the Reconciliation Bill, OBA, whatever you're familiar with. But when it comes to the new Medicaid work requirements, not having this CSEP program is definitely going to cause significant challenges in the older adult population. Next slide, please. So just a very quick overview of what this bill is, because there's too much in it to go over it in the last few minutes that I have. But this was a combination of major program increases, historically large cuts to Medicaid and SNAP, and the extension of 2017 tax cuts and new tax cuts. So the main thing here that we're going to talk about is those Medicaid cuts, which I'll talk about on the next slide. So there's nearly $1 trillion in Medicaid cuts over 10 years. But the part here that I wanted to highlight was that the new work requirements, and they're expected to start by December 31st of next year, this requires 80 hours of paid volunteer or educational efforts per month for individuals that are 19 to 64 years old. So this is what an individual would have to do in order to be eligible to receive Medicaid. So you can imagine for lower income older adults, the individuals that are using Medicaid are usually lower income older adults, or lower income individuals rather. And for older adults, it is going to be a little bit difficult to meet these requirements without that CSEP program. So this is the dilemma that we're in right now, and we're all trying to figure out what we can do as far as advocacy goes, to make sure that older adults, they have what they need in order to meet these requirements next year. So this is something that, again, is very important to know, because this program is under fire at this point. So just sharing what this program is, what it does, but also letting you know that unfortunately, we may not be seeing more of it very soon. Next slide, please. So what is next? There's a lot going on in DC every year around this time. We have the government shutdown, rumors and whispers around everywhere. And this is because the deadline is coming up in about a week on September 30th. The fiscal year 2026 begins on October 1st. And last week, the House passed a temporary funding bill to fund the government until November, but the Senate rejected it. So now we are back to basically a square one, and government funding outcomes are currently unclear. A shutdown could happen. So every year, this is something that could happen, and every year it seems like we only know until the last second. So the time for advocacy really is now. It's always advocate, always make your voice heard. You don't have to be a policy professional to speak with your members of Congress. They actually want to hear from you, oftentimes more than they want to hear from us, especially now. And I will say that even for sometimes when we're having meetings with Hill staffers, or staffers that are working for a member of Congress, they're asking us to bring a member of, they're asking us to bring a constituent, which would be an individual that's living in the area that they're representing in DC. So please don't be afraid to reach out to your members of Congress. And there are definitely advocacy materials and resources that we have that you are welcome to use if you decide to choose so. Next slide, please. So here's all of the materials that you can use for your advocacy. There's sample advocacy alerts that are suitable for everyone. We have an OAA fact sheet for education. We have a social media kit in case maybe you're not quite ready to engage with your member of Congress, but you still want to advocate for this. We have lots of resources on this page, and I'll be sure to plug this link in the chat as well for easier access. But all of that can be accessed on usaging.org/current issues and resources. And I believe this is my last slide, but we can hit the next slide. So here is our team here. If you have any questions, you're welcome to reach out to us at policy@usaging.org. I will say that for the CSEP program, we probably will not have all the details. If you're asking, maybe you're curious about what it's going to look like in the next couple of months, I'll be completely transparent. Even we don't know. But please, if there's questions that you have that we could potentially answer, feel free to reach out. If we don't know, then we will try and connect you with the person who would be able to best respond to that. So I will end here, and thank you so much for listening.
Olivia, thank you for providing us with the incredible overview. As an advocate, I had no idea so many of those tried and true programs in my community were funded by Older Americans Act. Not only is the advocacy around OAA clearly important to the well-being of impacted seniors, AAAs could very well be an effective partner for our advocates who support local and regional reentry efforts. So thank you. Similarly situated is U.S. Aging, is our next speaker, Rachel Gershon, a senior attorney with Justice in Aging. Justice in Aging is a national organization that uses the power of law to fight senior poverty by securing access to affordable health care, economic security, and the courts for older adults with limited resources. Previous to her role in JIA, Rachel spent a decade working with the state Medicaid system, seeking to make care delivery better, including working on reentry services and integrated health care for individuals dually enrolled in Medicaid and Medicare. She has a JD and a master's in public health from Harvard University. Rachel, we are excited to hear more from you and the good work that's taking place in justice and aging. The floor is yours.
Thank you so much. And I'm excited to be here today and talk about opportunities for healthcare access at Reentry for older adults, and also some opportunities for advocacy. Next slide, please. So we've heard a lot about the issue of older adults at Reentry. And at this point, when we're talking about people in this situation, I like to take a deep breath and just think, what would it be like, right, to get into a community and you've never seen or worked with some of the technology that's around, smartphone apps, all sorts of things that we take for granted, maybe something that's new or something that's unfamiliar for a person trying to navigate. So we know that nearly a quarter of all individuals in prison are over 50 years of age. And this is really due to some harsh penalties that came in the 1990s with long prison sentences. And now we are looking at the consequences of those policy choices. Older adults in prison face more mental and physical health challenges than their community dwelling peers, including higher rates of cognitive issues and more issues navigating activities of daily living. And then access to healthcare is really essential at Reentry. You can imagine at the point of most stress of trying to, navigate your sobriety, navigate your physical and mental health, having that access to be able to make an appointment, set up a relationship with a provider can be really essential right at the beginning. Next slide, please. So there's a lot of healthcare options at Reentry, and it can really vary depending on which state or locality you're in. So I'm going to do kind of a broad brush of what's available and kind of where to go for resources if you think the person you're working with or you yourself may fit into a category. So broadly, Medicaid is available to low-income individuals, and eligibility can vary by state. Medicare is available to older adults and people with disabilities. Other options include private health insurance, including that available through the ACA exchange. Often there are subsidies and you can find plans with $0 premium. So even if a person is not eligible for Medicaid or Medicare, there may be low cost options on the market. Insurance can also be available through a current or former employer. So thinking both about if a person is currently employed or they might have a retirement plan or other options that they haven't thought of yet in terms of healthcare access, including veterans coverage. Next slide. So I'm going to focus on Medicaid and Medicare during this presentation. One thing I want to note at the very beginning is healthcare access can be very complicated. I've worked as a healthcare navigator for 2 decades, and I'm still learning new things, which honestly should not be the case, right? This system should be much more simple for people to be able to access. But that said, it is very complicated. If you run into issues, if you run into complications, just know that lots of other people are running into these complications. There's a network of experts who are looking at this and eager to help. Please feel free to contact me if you have questions about Medicare or Medicaid access, especially around reentry issues. We want to hear where the problems are occurring, and we want to provide advice and assistance information about how to perhaps solve issues on the ground. And if these issues are systemic, we want to hear about information so that we can tell policymakers how to make the system better. So for Medicaid, it's available to low-income individuals. Eligibility can vary by states quite a bit. And then there's many organizations that can help with applications, including local Medicaid offices, Affordable Care Act navigators. They're actually required to screen you for Medicaid, hospitals, and other assisters. There's state websites that have information on eligibility and enrollment, and then there's other resources that you can use to screen if you are eligible. Next slide. So many states have what's called reentry demonstrations, which is kind of a fancy way of saying that states have asked for some flexibility around federal law to make it easier for people to both access Medicaid at reentry and then access services pretty quickly. So if you're working in a particular state, it would be helpful to kind of look up and see if your state is engaged in one of these reentry demonstrations. These demonstrations are fairly new, so they may just be a couple years old, or they may just be implementing right now in your state. Part of the demonstrations include some required care, so case management pre-release. So that means before a person leaves jail or prison, someone comes and talks with them, listens to their situation, and helps connect them to services. There's medication-assisted therapy to assist with substance use disorder, and a 30-day supply of medication and assistance accessing services in the community. And there's additional services that a state may be providing as part of these reentry demonstrations. Next slide, please. So now I'm going to turn to Medicare, which, as you likely know, is a major source of healthcare for people 65 and older, as well as people with disabilities. And it may be the only coverage that an older adult is eligible for, especially if they have some additional income or resources, assets. Medicare can often offer better provider networks because they pay providers more than Medicaid. And also, one reason why screening for Medicare is important for people at reentry is that, unlike Medicaid, Medicare is designed to start when a person first becomes eligible. So if you are late in enrolling in Medicare, that can actually result in late enrollment penalties, like extra money that you have to pay in order to be in Medicare later on down the line. And one thing I want to emphasize is individuals can enroll in both Medicaid and Medicare at the same time. Next slide. Here are some Medicare resources. There's some networking and referral resources. I highly recommend the SHIP network. They are an unbiased, federally funded network of counselors that can help sort through Medicare questions, including, as you may know, Medicare can be expensive with premiums and cost sharing. So they can help screen for something called Medicare savings programs, which are actually a Medicaid program, but it's a Medicaid program to help pay for Medicare premiums and cost sharing. So SHIP counselors, very good resource. There's also an opportunity for reentry advocates to connect with local SHIP programs. So if you're looking at your area and trying to figure out how to improve access to Medicare at reentry for a group of folks, reaching out to your SHIP counselors and seeing if you can have some sort of referral program, or if you can come in and provide training for your local SHIP counselors on reentry and what to look for individuals reentering, that might be helpful. We have some written resources from the Centers for Medicare and Medicaid, including Medicare.org, which is just kind of general access to Medicare. Medicare and You, which is an annual publication that provides pretty great information on just basic enrollment and what services you may be eligible for through Medicare. And then finally, the Centers for Medicare and Medicaid Services has a website called Incarcerated Medicare Beneficiaries that goes a little bit more in depth. Next slide, please. So when we think about Medicare and enrolling, there can be a number of issues that come up. And I think the big message around this is these are issues that have solutions to them. So if you see someone who's dealing with this kind of healthcare access issue or Medicare access issue, please get in touch with me or get in touch with your local resources, SHIP counselors, to try to figure out the pathway to solving the issue. So some of the issues we see include late enrollment penalties. So for example, if somebody turns 65 while incarcerated, They are technically eligible to sign up for Medicare, but since Medicare won't pay for almost any services within the prison system, it doesn't really make sense, right, to sign up and then pay premiums for a service where you're not going to get coverage. So when a person comes out after 65, let's say maybe they're 67 or 68, they may be facing late enrollment penalties as they come into the community. And there's a special, it's called a special enrollment period, a post-incarceration SEP, apologies for the acronym, that can really help with that late enrollment penalty and also help a person sign up for Medicare anytime during the year after they reenter. And we have an issue brief that is linked on this page, and I will also provide that you can access to see more details. There's navigation of enrollment and managed care options. So as you look at your enrollment possibilities, there's a lot of what's called Medicare Advantage plans and also Medigap. There's just a range of options to choose from. And SHIP counselors are really expert at helping people sort through what their options are, what the trade-offs are for staying in original Medicare or signing up for Medicare managed care. There's accessing these Medicare savings programs that can help with premium and cost sharing assistance. Again, Medicare can be very expensive, so getting on those Medicare savings programs can be very helpful. It can also be helpful, frankly, to deal with late enrollment penalties. And then finally, dealing with past due Medicare premiums. We see a situation sometimes when somebody is on Medicare and then becomes incarcerated. They will stay enrolled in some parts of Medicare for a number of months before they're cut off for non-payment of premiums. And those premiums that they didn't pay, even though they were incarcerated, they may be due when they come back into the community. So that can be a sticker shock of a bill, right? $300 for Part D premiums that you didn't pay when you were first incarcerated. There are ways to address that. We have an issue brief about how to deal with past due Medicare premiums, and happy to give more information about that if that is a situation that you come up against. Okay, next slide, please. So recently, there's been some changes to Medicare. I kind of put this at the end because it gets really wonky when I try to describe what these changes are. So I'm going to do them with broad brush strokes. But just to let you know, the big message is, if you had a situation a few years ago where somebody had trouble getting onto Medicare right after reentry, or had trouble with CMS paying for services at reentry, those problems may have been fixed through a federal regulation change that took effect this year. So just so you're aware that the situation is broadly getting better. So even if you encountered a situation before where somebody was not able to access care, they may be able to access care now. So recently, there's been a change to federal regulations to make access to Medicare at reentry better, and it's effective January 2025. The two big changes that happened is that special enrollment period that I talked about, which helps you sign up for Medicare any month during the year and also helps you sign up without owing those late enrollment penalties. That was clarified to say, for sure, it was kind of a question before, but for sure, if you're on parole, on probation, in a halfway house, other statuses, you're eligible for that special enrollment period. And I have linked our special enrollment period brief that goes into more detail about who's eligible. And then the Medicare payment regulation is the second thing that changed. In the past, if you had someone, for example, who was on probation and enrolled in Medicare, but they were having trouble getting their bills covered by Medicare, that has been fixed as of this year. And we have a fact sheet available talking about the issue as it was before, where sometimes CMS decided not to pay bills, even if a person was enrolled, and how it's been fixed now. Next slide. As we all know, there was a big bill that passed this summer. I'm going to call it HR 1, and it's going to affect access to Medicaid, Medicare, and other healthcare programs. I want to have kind of a broad headlines approach to this, because one of my big concerns right now is that people will assume because of HR 1 passage that they're not eligible for Medicaid and Medicare. And often that's not the case. People are still eligible. There are provisions that are going to come into place as time goes on that may affect eligibility. But again, for example, work requirements don't apply to people who are on both Medicaid and Medicare. Work requirements don't apply to people who are 65 years or older. So there are a lot of ins and outs that we're working through. We welcome your questions so we can help understand how to message this so people can understand how eligibility is affected. And then also understand the states have a lot of power here. They're going to be facing much more restricted budgets because of the way HR 1 is built. It's a massive transfer of basically money that has to be spent from the federal government to the state. So that's going to squeeze state budgets. But states still have the opportunity to make choices to preserve coverage and preserve access to services. Next slide. Here is our landing page for reentry for older adults on the Justice and Aging website. And next slide. And please feel free to email me with any questions. We really want to hear what you're experiencing, if people are experiencing barriers to healthcare access at reentry, and we appreciate you. Thank you. Next slide.
Rachel, I want to thank you so much for such a thorough presentation about Medicare. We really appreciate it. But I do have one question I want to ask you, and that is, what does a change to in-custody policy for Medicare enrollment mean for people who work in reentry services at the local level?
Absolutely. So a few years ago, we were facing the situation where sometimes a person left jail or prison and they weren't sure if they could access Medicare right away. And that has been fixed through the changes to the special enrollment period that are effective this year. And then also there were changes earlier that made it better in 2023. In addition, we ran across folks who were having trouble, even though they were enrolled in Medicare. CMS assumed if you were on probation or parole that somehow your prison was paying for your health care, which is not how it works. So we were able to work with a lot of advocates, many of you on the call. Thank you so much, to get that regulation changed. So now if you're enrolled in Medicare and you're on parole, on probation, you should not be seeing CMS deny bills based on the fact that you're on parole or probation. So it expanded access to Medicare at reentry, both enrolling in Medicare and then getting your services paid for once you were enrolled in Medicare.
Right. Thank you so very much. We appreciate you being here today. And I want to note for the attendees that all slides will be distributed post-event, inclusive of all the resources and links that were shared. Now, transitioning to Dr. Ron Self. Ron Self worked in special operations in the United States Marine Corps for 10 years before finding himself serving 23 years in prison. Dr. Self founded Veterans Healing Veterans from Inside Out in 2012 while incarcerated in San Quentin, and was appointed executive director in 2018. His organization is directly responsible for creation of the Veterans Yard model at the Correctional Training Facility in Soledad, California, which serves as a central hub. VHV has enabled vital housing support to returning veterans during their transition from prison back into greater communities. Beginning in 2022, Ron served on the National Veterans Justice Commission, convened and created by the Council on Criminal Justice, and whose recommendations continue to inform policymakers. Ron, we are so glad that you could join us today. Thank you for being here. And I would love to start off with you sharing a little bit about your experience with veterans and reentry.
Yeah, thank you for having me. My experience, it's interesting listening to the two previous speakers. There's a lot of good information there. For veterans, the reentry spirit is a little different. I've always had this belief that once a veteran is made aware of and has access to what's available to them, there's no reason for them to reconsider and go back to prison. There's just so much available to veterans that are not available to the rest of the population. And listening to those two previous speakers, there's just a wealth of stuff there that's very much needed. And many of the people inside prison, I'm aware, aren't aware of any of that. The ones that aren't veterans. For the ones that are veterans, even so, obviously, if you're an honorably discharged veteran, you're pretty solid. It's just a matter of connecting the dots. If you have an other than honorable discharge, that starts where things start getting a little wonky. Back in 2010, when President Obama signed the No Homeless Veteran by 2015, that failed miserably, predominantly because there's a large majority of veterans that have other than honorable discharges and bad conduct discharges, and housing and medical wasn't available to them because of that. Since then, the VA changed it in 2023 to where now, if you have an OTH, you're available for transitional housing and HUD-VASH, which is permanent housing. It's just like Section 8, but it's HUD-VASH for veterans. The ones still left out on that are the bad conduct discharge. They still have nothing coming. Interesting that you can have an OTH and still, for VA purposes, receive monetary compensation. So I'm honorably discharged, and I have 100% service connected through injuries I got in the military. A person that has an other than honorable discharge, for benefits purposes only through the VA, can get that upgraded or changed to where they can receive monetary compensation, but their reenlistment code remains such that they can't reenlist. So for DoD purposes, it's still an OTH. For the VA, it's an OTH with a different code that allows them to receive benefits for PTSD or missing a limb or whatever, which is really huge. And most veterans that I encounter across the nation have no idea about any of that. I mean, I wasn't even aware for 17 years that I was eligible for 100% service connected and could have been receiving that monthly compensation had I known. I just didn't know. And oddly, it took me going to prison to find it out.
So, what are some myths that you have encountered in the fair chance landscape as it relates to the veteran community?
Well, I mean, I hear it all the time from guys, and I don't understand it. They're in prison, and they think because they're in prison, they don't rate. They don't even consider themselves veterans. On the commission, the Veteran Justice Commission, one of the first things we had to tackle and identify was what is a veteran? Because even the VA doesn't recognize every person as a veteran. For me, as soon as you raised your hand and swore allegiance and you went off to boot camp, you're a veteran. However, there are people that get hurt in boot camp and get medically discharged and have 100% service connected, but they never served a day in the military. They got injured in boot camp. They are a veteran by definition. They just got hurt in boot camp and they aren't. Reservists run into a lot of problems if they don't have over 180 days active duty. They don't qualify for a lot of benefits because they aren't considered active. They're reserve units. Reserve units qualify differently than active duty personnel. So there's some things there that still, I think, need to be worked out. They're still working them out. The VA is really making a huge, and I have to be fair, they're making a hugely concerted effort to fix what's broken. At the same time, I know many veterans that have committed suicide dealing with the VA because they make it so difficult.
Yeah. Unfortunately, yes.
Yeah, sadly, the best that we can do is support each other. I mean, that's the major premise behind Veterans Healing Veterans, is a lot of people don't have family anymore. They don't have that biological family anymore. Bridges burn, people pass away, whatever. They feel excluded because of their discharge from the military, the only family they actually had left. We at Veterans Healing Veterans bring people on and we become your family. That's one of our ethos. Once you take a seat on the bus, you always have a seat. You may not be wanting to do the program that we have going at the time. That's okay. you can get off at this stop and we'll pick you up next time around or whenever you're ready. But we're always trying to remain there and be a resource for people that just don't know what to do. I get calls all over the country daily. Just yesterday, Ohio prison system called me asking me about how to identify the prisons they have in custody that don't want to identify. VRSS is a good system for that. They're there, the names are there. It's just most people don't know how to access the names.
So let me ask you a question. How has California responded through policy supporting veterans reentry where you are, since you're in California?
Yeah, so where I'm at in California, I mean, CDCR, California Department of Corrections and Rehabilitation, they've really done a paradigm shift in the last 8 or 9 years. They really are about reform, reentry, and successful reentry. And they're doing everything they can to do that. I mean, for example, the legislative body giving me $4.1 million to create the first veterans hub in the nation, a prison yard that is dedicated solely for veterans. The idea of having the VA there 5 days a week for staff and residents, and preparing everyone before they go back into society, the benefits that they weren't really aware they had when they left the military that often led to them coming to prison. So California is really doing more than most in relation to that. Colorado's really doing a good job. Every state's a little different. It's not like when the feds, they control everything. So when they do something, it's across the United States, period. Whereas each state, obviously, it's different. Virginia is really stepping up. We're working on trying to go out there and offer our program. They're really stepping up and asking appropriate questions. So California leading the way in some ways, other ways not.
So with individuals on this call that work in reentry, how can they better support individuals who are incarcerated, who are veterans, who have served in a uniform?
Well, in California, for instance, and I don't know what the other states have, they have something called CalVet. The CalVet hired people. They hired like 7 people. They trained them to be veteran service officers. They divided 31 prisons up in California up, and they go out to these prisons and they make sure the veterans that are there are enrolled in the healthcare system, that they're filing for their benefits that they may have coming that they're not aware of. And in general, it's just giving the information if you're there. Most veterans, not most, I shouldn't say that's not fair. Quite a few veterans will not self-identify. They want nothing to do with the VA because of shame, something, the fact that they're in prison, they don't think they rate services. Well, they do. Often the reason they're in prison has something to do with the military. And we try and educate them on that. That you don't have to be ashamed. You serve. Let's see what we can do to offer you resources or get you connected with resources on reentry. Housing is the most important one for reentry. It truly is. We do the work inside of helping them identify where they made those poor choices. That's all fine and dandy, and they grow in the introspection and the emotional maturity. But if they don't have a safe place to go when they get out, it's all for naught. So the transition out, the housing is the most important, I feel, for veterans and non-veterans. You have to have a stable environment for a minimum of 6 months. Most of the people we deal with, 90% of the people I deal with, they've been in prison for over 20 years. I myself served 23 years in California Department of Corrections. I was fortunate that I paroled into a program that I created helping veterans that was funded by the Department of Corrections. And since then, we've received quite a bit of funding to continue doing and expand what we're doing. So it's just about making the people that are helping the veterans aware of all the resources. The best thing you can do for a veteran, if you don't know and you're not used to dealing with veterans, every city, every county has a VSO officer. It's usually at the courthouse. Find the veteran service officer and connect those two. Make an appointment immediately. More importantly, make the connection while they're in prison, doing that time, and the clock is ticking, and their claim could be being evaluated while they're in prison, so that when they parole, they have resources available in their pocket.
And I have one more question for you. And you partly answered it, because my question was going to be asking you what you would recommend for someone that's coming out now that's a veteran, what they would do. Also, and the additional question to that, because we don't think about the families that are supporting the veteran that's coming out, what would you recommend for the family that's supporting those veterans that are re-entering? What would you recommend that they do to support them as they're coming out.
The same thing I recommend for case managers and people that are providers. Get a hold of the local veteran service officer. Go talk to them. Go to a VFW hall, Veterans of Foreign War, American Legion Hall. There's all kinds of elder veterans there that have a tremendous amount of experience and have navigated a lot of things related to family members and what it's like, especially for wives whose husband came back from war different, got in trouble, went to prison, and now it's even more different. Again, it's reaching out to the local veteran service officers and communities and organizations in your area, and they're already doing that work, is what I found.
Thank you.
I wasn't sure about that first question.
Oh, you got it. You covered everything.
Something else I wanted to mention for people that are involved is NICC, National Institute of Corrections, put out a document several years ago. They put out 3 documents: Barracks Behind Bar 1, Barracks Behind Bars 2 and 3, VHVs featured in 2 and 3. And what that is you can just Google it, and it's a report on people creating pods in county jails for veterans specifically. California's doing it largely. I don't know about other states, but it's a how-to. It's the pros and cons of creating a pod for veterans in county jail to intercept them and connect them with the resources like Veterans Justice Court. I'm currently working with the San Francisco Veterans Justice Court. We work with the veterans that have encountered the law, and we're working to get them back on track and get a hold of the benefits they have. The Barracks Behind Bar 1 is where I got the idea of creating an entire prison instead of just one pod. There's a lot of good information in there. There's a lot of connecting the dots in those documents. I really would suggest you go look at those. Anyone interested in this arena.
Thank you so very much. I appreciate you. Wish I had known you when I was coming out. Also, I want to direct the attendees to the resources on the screen. These are resources that are specifically for veterans, people who have served in uniform, and you might want to take those down. We will surely provide those at closing. You'll be provided those. And now we will transition to anyone who have questions that they would like to ask the panelists.
Actually, I see one here about food, which is food and medication are really big, and you kind of covered that. A lot of the stuff that's available to civilians, there's one extra thing I've noticed, at least in California, in the Monterey area, especially the Veterans Transition Center in Marina, California, and many veteran organizations have a pantry. That pantry is for any veteran in the community that is falling on hard times. Sadly, we have active duty personnel coming to the pantry. I mean, people that are active duty, living on base, DLI, naval postgraduate, not many, but occasionally, that they're having to come to supplement their food stores. And I've noticed that there's a lot of food pantries for veterans and civilians in every county. You just got to go find them and get your pride and your ego out of the way. Because I found for a lot of veterans, that is a negative. Pride and ego gets in the way of seeking help.
Thank you. It is 11:58, and we want to, 12:58. We want to be respectful of everyone's time. So as we draw our time together, as we draw our time together at the table to a close today, I want to start by thanking our incredible guests. I am confident that what you've shared today will lead to a deeper understanding of the current landscape of resources essential for those aging in reentry, as well as the work ahead of us as the moment to ensure elders can reenter to opportunity and access. Before we adjourn, I ask our viewers to please use the QR code on the final slide on the screen to complete our survey and let us know feedback from today. As always, if you haven't done so, follow us on social media, and please remember to share the opportunity to join the JCC with your circle. Finally, we encourage everyone in the JCC to complete our advocacy survey. This is how we help create programming just like this, and also how we shape the coalition. For those enrolled, you also recently received information about our new federal advocacy listserv. Stay tuned to our social media and the listserv for upcoming announcements of how you can engage. Thank you for joining us today and have a great week.